Non-surgical treatment for breast cancer really includes any treatment that's not an operation for breast cancer, and they can roughly be divided into radiotherapy, which targets a specific area of the body, and systemic therapy, which, as its name suggests, targets the whole body, and that can include chemotherapy, hormone treatment, and other more modern targeted treatments, and immunotherapy. We use these treatments in several different settings. So for some patients, it will be appropriate for them to have systemic treatment, usually chemotherapy, before having an operation for breast cancer. And that might be to shrink the cancer down to allow a better operative outcome. And in many cases, we then give systemic therapy after surgery for breast cancer to reduce the risk of the cancer coming back in the future. And we also use radiotherapy in that setting. Some patients of mine will present with disease that has spread or has metastasized away from the breast and the lymph nodes to other parts of the body. And in that scenario, we use those treatments to control the disease. And the aim of treatment in that setting is to maintain or improve the patient's quality of life, to allow them to do the things that are important to them, and also to lengthen the patient's life expectancy in that circumstance. For early breast cancer, so for usually women with lower risk breast cancer who've had breast conserving surgery, the most common things that we would use would be radiotherapy and endocrine or hormonal treatment. For patients with different types of breast cancer or cancer that has spread away from the breast, then the common things we would use would be chemotherapy, but we're also increasingly using hormone-based treatments with the addition of other targeted treatments to avoid the use of chemotherapy where possible. This can be quite a difficult question to answer because the effectiveness of a treatment depends on the scenario that we're using it in. However, if you put together all the treatments that we use before or after surgery for breast cancer, we know that they significantly reduce the risk of cancer recurring, and that might be cancer recurring in the breast or somewhere else in the body. The benefit of treatment tends to be higher in patients who have higher risk disease, which is why we tend to opt for more intensive treatment regimens in those patients. We know also that the treatments continue to reduce the risk of cancer recurrence for many years or decades after those treatments have finished. And in the metastatic setting, we now are in the situation where for many patients with metastatic disease, we start treating this as though it is a chronic or a long-term illness. And we have many patients who've been on treatment for a number of years. Side effects that patients tell me about often relate to feeling fatigued or lethargic, and that can be a side effect from treatment or from the cancer itself. So tiredness, finding that perhaps the things that they used to do are a little bit more difficult than they used to be. That tends to be more the case when we're treating with curative intent. And when we're treating patients with metastatic disease, we do our very best when they're on longer term treatment to minimize that side effect. People also tell me that they get changes to their nails, to their skin, and of course people are familiar with hair loss with cancer treatment, and that doesn't happen with all of our treatments, but if it does, we have some techniques we can use to reduce the risk of hair loss. As a consultant, the side effects that I worry about or think about are risk of infection, and those infections can rarely be serious, and risk of blood clots and risk of allergic reactions. But luckily, we've got a lot of processes and protocols in place to reduce the risk of those things happening. And we always discuss those risks with a patient before embarking on a treatment course. All patients with a cancer diagnosis are discussed in a multidisciplinary team or MDT meeting, and those happen in all cancer centres around the country. They're attended by surgeons, pathologists, radiologists, oncologists, and specialist nurses. And in that meeting, the entire team will decide a treatment plan for that individual patient, and that will be based on the patient's cancer, the particular features of the cancer, and the individual involved as well. So the patient's fitness and their own wishes would be taken into consideration. The outcome from the MDT is advisory, and what that means is that when I, as a consultant oncologist, meet the patient, I will discuss the recommendations from the MDT, but there may be changes made to that depending, for example, on the patient's fitness or any particular concerns or wishes that that patient has. So the final treatment decision rests with the treating consultant in conversation and in conjunction with the patient.